Welcome back, everyone. Today we are diving into one of those bread and butter clinical scenarios that every student and resident will see in the ER. Picture this. An elderly woman trips on a rug, falls on her outstretched hand, a classic Fuchs injury, and she comes in holding her shoulder in agony. There is a specific spot on the humerus that is basically a ticking time bomb for her nerves. Dr. Sara, are we talking about the anatomical neck or the surgical neck today?
We are definitely focusing on the surgical neck, Dr. Khan. While the anatomical neck is that slight groove just below the head of the humerus, the surgical neck is the constricted region just distal to the tubercles. It's called the surgical neck precisely because it is the most common site for fractures that require orthopedic intervention. From a board perspective, this is a high-yield favorite because of what's hugging that bone.
Exactly. I like to think of the surgical neck as a narrow mountain pass. It's a bottleneck. You've got these vital travelers, the neurovascular structures, trying to squeeze through a very tight space right against the bone. If that mountain pass collapses, those travelers are in big trouble. So, Sarah, who are the unlucky passengers in this pass?
There are two major ones to memorize. First, the axillary nerve. Second, the posterior circumflex humeral artery. They both wrap around the surgical neck of the humerus. If you see a question about a fracture in this specific region, your mind should immediately jump to these two structures. This isn't just anatomy. It's a classic board exam 1-2 punch, where they give you the fracture and ask you for the deficit.
And why does this matter clinically? Well, if that axillary nerve gets crushed or stretched during the fracture, your patient loses more than just bone stability. They lose the power to the deltoid and the teres minor. Think of the deltoid as the heavy lifter of the shoulder. Without it, you aren't lifting your arm to grab a coffee off the shelf. But even more importantly for the physical exam, look at the shoulder shape.
That's a great point. When the deltoid atrophies due to axillary nerve damage, the shoulder loses its normal rounded contour and starts to look flat or squared off. But Dr. Khan, before the muscle even atrophies, how are you testing this in the acute setting of a fracture?
You have to check the regimental badge area. That's my favorite analogy. Imagine a soldier with a patch on the lateral side of their upper arm, right over the deltoid. That specific patch of skin is the territory of the upper lateral cutaneous nerve of the arm, a branch of the axillary nerve. If the patient can't feel you touching that badge, the nerve is likely compromised. To be the doctor of choice in a busy emergency department, you have to be the one who does this sensory check before you even look at the x-ray. It shows you're thinking about the whole patient, not just the break.
Precise as always. Now, for the students listening, the boards love to test the quadrangular space. This is the anatomical doorway these structures pass through. Dr. Khan, how do you visualize the boundaries without just memorizing a list of muscles?
I visualize a literal window. The top of the window frame is the teres minor. The bottom is the teres major. The sides are the long head of the triceps medially and the surgical neck of the humerus laterally. The axillary nerve and that posterior circumflex humeral artery are basically jumping through that window together. If the lateral side of the window, the humerus, breaks, it's going to shatter the glass and take out those structures.
Perfect. And we shouldn't forget the vascular side. While the nerve causes the long-term functional loss, that posterior circumflex humeral artery is vital for the blood supply to the humeral head. If you disrupt that, you're looking at a risk of avascular necrosis. It's the same concept as the femoral neck and the hip. If the blood supply is cut off at the neck, the head of the bone can literally die.
Which is a nightmare for the patient. Why does this matter clinically? Because if you miss a vascular injury, that patient might have a healed bone that eventually collapses anyway. You have to check for swelling and distal pulses, even though the radial pulse is way down at the wrist. A huge hematoma in the axilla is a red flag that the circumflex vessels are leaking.
Let's pivot slightly to a common distractor on exams. Often they'll compare a surgical neck fracture with a midshaft fracture. In a midshaft fracture, you're worried about the radial nerve and the spiral groove. But in the surgical neck, it is strictly axillary nerve. Students often mix up the drop. Is it wrist drop or a loss of abduction? For the surgical neck, it's the loss of that initial 15 to 90 degrees of abduction.
Right, because the supraspinatus starts the first 15 degrees, but the deltoid takes over for the rest. If the axillary nerve is out, you're stuck. It's like having a car that can only idle but can't actually drive down the highway. So, Sarah, if we had to boil this down for the student's final review before an exam, what are the must-knows?
Okay, here is the high-yield summary. 1. The surgical neck is distal to the tubercles and is the most common humeral fracture site. 2, the axillary nerve and posterior circumflex humeral artery are the structures at risk. 3, clinical signs include loss of the rounded shoulder contour and sensory loss over the regimental badge area. And 4, the functional deficit is impaired arm abduction above 15 degrees.
And my clinical takeaway, whenever you see an elderly patient with shoulder pain after a fall, don't just order the film. Check the skin sensation over the deltoid and look for that squared off shoulder. Those physical signs tell you the story of the axillary nerve long before the radiologist calls you back. Great session today, Dr. Sarah.
Always a pleasure, Dr. Khan. Study hard, everyone.